Hi, I'm Amy Smith. I'm the Bariatric Program Manager here at Northeast Georgia Medical Center. Congratulations on reaching out for more information about your treatment options for obesity. My team and I are very excited to walk you through the process. So to begin, we're going to talk about the definition of what is obesity, what are the treatment options that are available to you, review the risks and benefits of these different procedures that are available. Then we'll talk a little bit about the dietary changes that are necessary to maintain weight loss. I'm going to show you some videos of the surgeons. And then for you, your next step would be letting me know how you would like to move forward. You have a few options. You can make an appointment with our bariatric dietitian to begin some medical weight loss. You've got options that are non-surgical, and you've got some surgical options too that we're going to go over in detail here. So obesity has been defined as a BMI or body mass index of 30 or greater. We know that obesity is chronic, relapsing, and it's multifactorial, meaning that there's a lot of things that lead to obesity. What we know is that there's a psychosocial component to obesity. Sometimes immunity, genetics, and even environmental things can lead to obesity, as well as impacts from your endocrine system, your metabolism, and other medical issues. Obesity is driven by hunger hormones. So our body secretes a chemical called ghrelin. That's your hunger hormone, and it's secreted from your stomach. It makes you feel hungry. And what we know is that patients who suffer from obesity have an overproduction of this chemical, ghrelin. There's another one that's called leptin. When leptin is secreted, our body feels a decrease in appetite, and there's also an imbalance with that hormone in obesity. In 2013, the American Medical Association officially recognized obesity as a disease. This did several things for us in the medical community. It increased the treatment plans for our patients and the treatment options. This helped get bariatric treatment available to more patients because more insurance companies have begun to cover it. It also helped to decrease the incidence of type 2 diabetes. Specifically with the gastric bypass, we're able to put type 2 diabetes in remission a great number of the time. So that's a big deal in our population of patients. It also has helped us to decrease the stigma associated with obesity and help to better educate care providers in the treatment. What we know is that obesity wreaks havoc across the entire body. It is very common for me to see patients that suffer from anxiety, depression, and low self-esteem related to their weight. But even more so, when we look at the effects of obesity on the body, it impacts every organ system. When we look at the lungs, patients can develop asthma or sleep apnea. Patients also can suffer from high blood pressure, high cholesterol. In the endocrine system, they have an insulin resistance or type 2 diabetes develop. But for female patients, they can also develop menstrual irregularities, polycystic ovarian syndrome, and infertility. Did you know that there are certain cancers that are increased by obesity? We also have kidney issues, liver issues. We have an increased incidence of gallstones and non-alcoholic fatty liver. But then on top of that, with the weight on our bodies, patients can begin to suffer from back pain, joint pain, and even foot pain. Measuring the level of obesity is done by a calculation looking at your height and your weight. This helps us to tell us how severe your obesity is. So before I told you that obesity is defined as a BMI of 30. When we reach a BMI of 30 or greater, you're considered to be obese. But when we hit a BMI of 40 or greater, you're looking at morbid obesity, which means that your lifespan can be cut short due to your weight. We have several options. The first of those is a non-surgical option called the Intragastric Balloon. Now, this procedure is only a self-pay option because insurance companies don't pay for it. But for some patients, this could be a good option for weight management. This particular procedure is limited to those who have a BMI between 30 and 40. This is a patient that really only needs to lose about 30 to 50 pounds. This procedure can be done endoscopically, as when the patient is sedated and the physician runs an endoscope down their throat and into their stomach. Or there's an option where it can be done where you're not sedated and you swallow a capsule in the doctor's office. Usually the procedure takes about 30 minutes and the balloon stays in place for 6 months. Here's the first option. It's called Orbera. This is the procedure where the patient is sedated and they use an endoscope to place the balloon. You can see here that the balloon is now in the stomach after the scope went down the esophagus. The surgeon has now inflated this balloon with about 500 to 600 cc's of saline. This balloon weighs about 1.5 pounds. It occupies space in the stomach. Therefore, you're not able to eat as much, you feel fuller faster, and you lose weight. The balloon can only stay in for 6 months though, so it's very important that you're working with a dietitian and you're learning meal planning and how to basically decrease the amounts that you're eating, so that when the balloon comes out after 6 months, those behavior modifications have already been made and you're able to maintain the weight. This next example is of Obalon. This is the one that can be done in the surgeon's office by swallowing a small capsule, and this one is actually blown up with gas, so it's lighter. With Obalon, you will swallow more than one balloon. So you'll start with the first one, and over time, they will add more balloons to your system. Again, same concept. You will be able to get fuller faster off of eating less food, therefore you will lose weight. This helps to decrease your appetite, but again, it's very important to follow up and be working on meal planning and portion sizes, as well as food choices. Now, to remove the Obalon balloons, you would need to be sedated, and the surgeon would then go down your throat with an endoscope, just like when they're doing to look on the inside of a patient's stomach in the endoscopy, and the balloons would be removed that way. Regardless of the choice, it can only stay in for 6 months at a time. And so here are the videos just showing you the removal of the balloon. The important things to know about the intragastric balloon is that your doctor will put you on anti-ulcer medications before and during the procedure, because there is an increased incidence of gastric ulcers developing because there's a foreign body in your stomach. You may also be put on anti-nausea medications. Some patients complain of nausea for the first 1 to 3 days after balloon insertion. This is a 12-month commitment. You need to learn to change some behaviors in regards to food, with food choices, portion sizes, and meal planning to set yourself up for success. You will have monthly dietitian visits, you'll be working with a behavior coach, and support group is very important to be successful. Potential complications: nausea and vomiting, mostly in the first 1 to 3 days after the balloon is inserted. Balloon failure and migration. Because this is a foreign body in your stomach, there is a potential that the balloon could pop. If it does, it could potentially migrate, meaning that it could go through your stomach and start to pass on into your intestines. If this were to happen, the surgeon would have to go in through endoscopy to retrieve that balloon, and you'd have to have the balloon replaced. There is a chance that you could be intolerant of the balloon. It's in your stomach. Some patients say that they can feel it, especially the one that's filled with saline because it's heavier. So if this were to be you and you couldn't tolerate it because your nausea didn't go away, the balloon would have to be removed. Again, the incidence of gastric ulcers increase because this is a foreign body, but we do put patients on medications to prevent it. Now we're going to move on to the surgical options. Surgical options would be for a patient of a BMI of 35 or greater. In this slide, we're comparing the difference between self-pay and insurance. On the left-hand side, you'll see insurance options. So if you have a BMI of 35 to 39.9 and your insurance company pays for weight loss surgery, you would need to have a health condition to go along with your BMI to qualify for surgery. Some of the most common ones that are approved through the insurance company are things like sleep apnea, high blood pressure, high cholesterol, heart disease, reflux, or type 2 diabetes. But if you're someone who is in this category of BMI and you don't have these conditions, I would still encourage you to see your surgeon, because sometimes they may find something else in your medical or surgical history that they believe would qualify you for surgery, and they can go to the insurance company on your behalf to attempt to get you approved. If you meet a BMI of 40 or greater, most insurance companies will not require a health condition associated with obesity for you to be a candidate for weight loss surgery. The reason behind this is if you are a BMI of 40 or greater, it's not a matter of if, it's a matter of when you would develop these other issues. If you unfortunately do not have health care coverage for weight loss surgery, then you would need to pay out of pocket. It is an expensive procedure, but remember, this is to get your health back and to be more active. So looking at a self-pay option can kind of be overwhelming, but I want to assure you we're here for you every step of the way. We have two companies that we work with that you can try to get approval through. One is called Prosper and the other is Health Credit Services. You can visit both of their websites and you can actually put your information in and attempt to get approved online. Or you can call if you need some more assistance. These procedures are expensive. You're looking somewhere between $18,000 to $20,000. You know, I had one of my patients that came to me years ago that told me he didn't have coverage, but his doctor told him he was going to die if he didn't have surgery. So he took out a medical loan, and he told me, Amy, people take out loans all the time for their house, for their car. I took out a loan for my life. So it can be done, and this is really important to get your health under control. For self-pay options, the BMI still is in effect, so you would at least have to have a minimum of a BMI of 35 or greater. The benefit of self-pay is that there aren't any extended wait periods or criteria that you have to meet for insurance, so you may be able to get to surgery faster. Types of bariatric surgery. There's two types of surgeries that we do here at Northeast Georgia Medical Center. One is called the vertical sleeve gastrectomy, and it is considered a restrictive procedure because it alters the size of your stomach, making it much smaller so that you feel fuller faster and you lose weight. The second one is called the Roux, or for short, gastric bypass. This procedure has been around longer than 35 years at this point, and it is considered a restrictive and a malabsorptive procedure. It's restrictive because your stomach is made much smaller. Instead of having a stomach the size of a football, your stomach's going to be about the size of a baseball. But also, the doctor is going to reroute your intestines so your body will not come in contact with all of the food and drink that you take in. And that's why it's called the bypass. It's going to bypass a section of your stomach and the first part of your small intestines. We're going to look at both of these procedures now in detail. First is the vertical sleeve gastrectomy, or called sleeve for short. On the left-hand side of your screen, you'll see the normal anatomy. You'll see the esophagus, your stomach. This section here is where the pylorus, or the valve or outlet at the bottom of the stomach is. That's what opens and closes to let food and drink outside of your body. And then there's the first part of the small intestine here called the duodenum, and later the jejunum. This is your normal anatomy. When the physician does the sleeve gastrectomy, over here on the right, what you see is a greatly reduced size of the stomach. So the surgeon has removed about 75% of your stomach, making it much smaller. Therefore, you're going to feel fuller faster. One of the benefits of the sleeve gastrectomy is this section of the stomach that is taken away is where that hunger hormone ghrelin is produced. So some patients after the sleeve gastrectomy will tell me that they're not hungry at all and they actually have to make themselves eat. The biggest thing to know about this is that those cells will eventually begin to grow back and produce ghrelin, that hunger hormone, again. So it's very important within the first 6 to 12 months after surgery to make some behavior modifications. Again, food choices, portion sizes, meal planning will be very important to you. And the most important rule after weight loss surgery, regardless of the surgical procedure, is to learn to not snack between meals, because this restrictive surgery will make it restrictive and make you feel fuller faster when you sit down and eat a meal. But if you snack all day, it's not going to be a help to you. So remember, this is a physical tool that's meant to help you, but it's not going to control snacking throughout the day. So here's a video of what the sleeve gastrectomy does. The surgeon will go in, and again, he will remove 75% of your stomach. The section of the stomach that he has cut away will now be completely removed from the body. So this is a permanent procedure. When it says that there's no long-term studies about the sleeve gastrectomy, it's because it has not been around as long as the gastric bypass. The sleeve gastrectomy has been around 15 to 20 years at this point, where the gastric bypass has been around greater than 35 years now. Risks and benefits. The benefits, there's no rerouting of the intestines with a sleeve gastrectomy. It does decrease the hunger hormone ghrelin because this is where it's produced. It limits the amount of food that can be eaten at once. The average national weight that is lost with the gastric bypass is about 50 to 66% excess weight loss. Now, I want you to understand this term. This means the national average. So this includes people who did very, very well with a sleeve gastrectomy, but also people who didn't completely make those modifications in their behavior and maybe just kind of made the minimum impact with their weight. So with that said, 50 to 66% is the national average, but I have seen patients that were very particular with their diet and their lifestyle modifications who hit a percentage of 80% excess weight loss, which is very comparable to the gastric bypass. So it's very important to learn those lifestyle changes. The risks with the sleeve, it is not reversible. We cannot put that section of the stomach that is removed out of your body back. There's also a higher incidence of post-operative nausea and spasms. The stomach is very muscular and it's a smooth muscle, so when we remove that section of the stomach, you may feel some nausea, but we can treat it in the hospital. Some patients also develop spasms after surgery. Again, it's a smooth muscle. Even though it's a surgical alteration, it's also an injury to your body, and so sometimes your stomach will spasm and get tight. The good news is that we've got medication for that can be put underneath your tongue. It will dissolve, and it's a smooth muscle relaxant for that stomach to make you feel better and help you get hydrated. You are less likely to develop dumping syndrome if you were to eat sugar or simple carbohydrates or fats because there's no rerouting of the intestines with a sleeve gastrectomy. It is likely to cause an increase in reflux. So if you suffer from acid reflux now and you have to take medications, this may not be the procedure for you, so you will need to discuss your options with your surgeon. Because the sleeve gastrectomy is shaped like a banana and it's thin and it's tubular, when that pylorus at the bottom of your stomach opens and closes, that natural valve, it causes a high pressure chamber, which means that your reflux could get worse. All of our patients are at risk for a staple line leak, both with the sleeve gastrectomy or the gastric bypass. The reason behind this is because when the surgery is done, the surgeon takes a stapler and he cuts and lays down staple all at the same time. I compare our surgeries to plumbing. If you take pipes apart and you put them back together, there's always a risk for a leak. So we do several things in the operating room to prevent this. The stapler cuts and seals all at the same time, laying layers of staple down on either side. The surgeon then goes behind that and he hand sews on top of that suture, that staple line. And then there's also a chemical that some of the surgeons use called Tisiol. They squeeze that medication and lay it down all along that incision line, and it's like super glue for tissue. So you've got 3 layers of protection. The last thing that they do is they flood the abdomen with saline, and through a tube in your mouth they inject air. And in the surgical field they're looking for bubbles. So if they see bubbles, it's kind of like checking a tire for a leak. If they see the bubbles, they know they've got a leak, they can find it and they can fix it before they leave the operating room. So that's our goal, is to fix that before we leave. The last thing is ulcers. All of our patients, regardless of the surgery that you choose, are at risk for gastric ulcers because this tissue is very sensitive. So all of our patients should avoid steroids and NSAIDs after surgery. NSAIDs are your medications like Advil, Motrin, Goody powders. So if you get in a situation after surgery, you want to reach out to your bariatric surgeon to say, hey, what do I need to do? Maybe you develop a sinus infection after surgery and your primary care wants to put you on steroids. That's a time to reach out to your bariatric surgeon because they may have an alternative for you, or they may wish to put you on some medication to protect your stomach while you have to be on that type of medication. So Roux or gastric bypass. So this is a more complex procedure, but this is the one that could get you the most weight loss, and also if you're a type 2 diabetic, this is the surgery of choice. This is considered the gold standard for the treatment of diabetes. So in this picture, this shows us the gastric bypass. Here's the esophagus. Here's the top portion of the stomach that was cut away from the remainder of the stomach. And what the surgeon has done is they've gone further downstream and they've brought the jejunum, the second part of the intestines, up, and they've now attached it here to your small pouch of a stomach. What you're left with here is the leftover stomach, what we call the remnant stomach. And then here's that little pylorus I was telling you about, the valve. And the first part of your small intestine is called the duodenum. Now, the stomach, the leftover stomach, and the duodenum still stay in the body. It's okay. It's not going to die. It still has the blood flow and it still has the nerve endings. It's still a fully functioning stomach. But what it's going to do for you in the gastric bypass is still produce that gastric acid. It's just rerouted downstream and reattached to the intestines further down so it can aid in digestion. So with the gastric bypass, you lose weight because your stomach is much smaller, this little pouch that they've made you. So you're going to eat less, feel fuller faster, and lose weight. But in addition to that, you're going to develop malabsorption because your body is now bypassed from absorbing food, drink, medications in this leftover stomach and the first part of your small intestines. So this is going to maximize your weight loss. Here's a video of the gastric bypass. So he's going to cut away the first part here, and now this is your pouch of a stomach. Remember at the beginning I told you it's going to go from a football size to more like a baseball size stomach. He's brought the intestines up. So now we're going to talk about risk versus benefits with the gastric bypass. The benefits, you're going to have a much smaller stomach. You're not going to be able to eat as much, so therefore it will limit your portions. Again, it's very important for you to understand this is a physical tool. We're here to help you learn how to use that physical tool. So if you were to snack all day or drink milkshakes, you're not going to gain weight loss. This is not the easy way out. You've got rules that you've got to follow. So if you were to drink milkshakes or snack all day, your body's still going to absorb those calories and you're not going to lose weight. However, if you were to be very particular with your diet, your food choices, and your portion sizes, and only eat 3 meals a day with no snacking in between, you're going to maximize your weight loss with your new physical tool. So there is an increased intolerance to carbohydrates, sugars, and fats, and you may be thinking, why is that a benefit? Well, with the gastric bypass, it is. If somebody were to struggle with a sweet tooth, for example, or they really have a hard time controlling their food choices, this may be the option for you because it's going to maximize your weight loss. If somebody were to eat something that was really high in fat or really concentrated in sugar, they're going to have issues. Because in our normal anatomy, if you were to eat those types of foods, it would go down your esophagus, into your stomach, into the first part of your small intestines, where it deconcentrates all of those sugars and fats. So that when it gets to the second part of your intestines, your body's able to take it in and no big deal, no symptoms. But with the gastric bypass, if you eat those types of foods, it's going to sit in your little pouch of a stomach and it's going to dump into the second part of your intestines called your jejunum. And your jejunum is not used to getting that concentrated fat or sugar dumped in there. And so what happens is your body is going to develop what's called dumping syndrome. Your body is going to give you severe abdominal cramping. You're really not going to feel good. It's going to be painful, and you're going to run to the restroom either to vomit or have diarrhea. It's going to cause an aversion to those types of foods for you, so that if you think of those foods after you've experienced it, you're not going to be excited about eating it, and it's going to cause an aversion to those type of foods. So that's why it's a benefit. We're here to do these procedures to gain you weight loss, and so that's important to remember. The bypass will limit the caloric absorption because it's not going to absorb all of those things in the leftover stomach or the first part of the small intestines, so you will get additional weight loss related to that. Now, this procedure can be reversible, but if you're looking for weight loss surgery, you shouldn't choose this because it's reversible. But I share this because some patients are concerned that years down the road when they get older, they may be limited as far as treatment for certain things. And that is something to take into consideration. And so for some reason down the road, if you were in need of a feeding tube, for example, because you weren't able to take food in, you could potentially have a feeding tube inserted in your leftover stomach. Remember how I told you it still had blood flow and still had nerve endings and it was a fully functioning stomach? That could later down the road be a benefit for you. Or in very rare cases, if somebody were to develop very severe malabsorption and they were very unhealthy on a low-weighted spectrum, then you potentially would need to have this procedure reversed. Again, it's a very complex procedure, but it can be done. Statistically, we know that the gastric bypass has been around for a longer period of time than the sleeve gastrectomy, and patients on average lose more with the gastric bypass. And so statistically, weight loss is maintained for a longer period of time with this particular procedure. There is a much higher resolution of type 2 diabetes with this procedure. And I think the statistic nowadays is somewhere around 86% of the time we can put patients into remission with the gastric bypass. So this is very important, and it's a very high incidence of putting your diabetes into remission. So when you have a conversation with your bariatric surgeon and this is part of your history, you need to take this part very seriously. The national average of weight loss with the gastric bypass is about 60 to 80% of excess weight loss. So again, this is a national average. Some patients did very well. Some patients just lost the minimum. And so just to share with you, I have seen patients lose up to 110 or even 125% of their excess weight loss if they were very particular with their food choices, portion sizes, and not snacking between meals. Risks with the gastric bypass: you do have a risk of nutritional deficiencies, specifically your vitamin levels. And actually that's quite true of the sleeve gastrectomy as well, because your body needs gastric acid to break down iron to absorb it. And so the top 3 deficiencies that we see after weight loss surgery are B12, iron, and vitamin D. So it's very important to take your bariatric vitamins after either one of these procedures. Now, there is a chance that you could develop a pouch outlet or anastomosis stretch with noncompliance. What I mean by that is when the surgeon makes that small pouch of a stomach and he brings the intestines up to the bottom, that is a hand-sewn outlet from the bottom of that gastric bypass pouch. If you were to overeat and put a lot of pressure over that outlet over time, you could cause damage to your gastric bypass, and it could completely open that up so that you feel no restriction at all. If this were the case, the surgeon would bring you into the office. You would most likely see a lot of weight gain, and he would do a procedure through radiology and x-ray so that he could see the anatomy of your pouch. And if this were the case, if you did damage it, you may have to have a revision and go back to surgery for this. Again, our patients are at risk with the gastric ulcers with this procedure, as we talked about with a sleeve, so no steroids and no NSAID medications afterwards to prevent that. And also no smoking. Smoking can make you develop gastric ulcers also. Again, with this procedure, our patients are at risk for suture line leak, as we discussed with the sleeve gastrectomy, and we talked about the things that we would do to prevent that in the operating room. The last thing to consider is that our patients after gastric bypass are at risk for something called an internal hernia. It doesn't happen very often, and if it does, it happens way down the road after you've lost a lot of weight. Because as our patients lose weight on the outside, you also lose weight on the inside. There's a connective tissue in your body called the mesentery, and it's kind of like an apron that kind of drapes over all of your internal organs. And that particular connective tissue is also made up of some fat. Well, when the surgery is done with a gastric bypass initially, as the surgeon brings those intestines that are usually further downstream up, he has to poke a hole in that mesentery and make a window to bring the intestines up through. So over time, if you lose weight, that connective tissue can get bigger and bigger and bigger in the section where that window was created. The intestines could potentially get caught up in there, and you would develop symptoms of an obstruction like vomiting, not being able to keep food down, and abdominal pain. If this were the case, again, it doesn't happen often, but if this were the case, the surgeon would have to go in, surgically make sure the intestines are in a good position, and then sew that window to make it smaller so that you would no longer have symptoms with that. Contraindications to weight loss surgery in general. If you're an active smoker, this is not the time to have weight loss surgery. Most surgeons will make sure that you have stopped smoking for 6 weeks. Some of them are stricter and say 6 months. Some of them even do a blood test to make sure before you have surgery that you've been compliant with this. Because when you smoke or you take in any type of nicotine products, including e-cigarettes, patches, or gum, that nicotine causes vasoconstriction, which means that your vessels constrict down and get smaller, which means it severely limits the blood flow to your organs. And your stomach tissue is very sensitive. So if you're smoking or you take in nicotine like that and your stomach isn't getting the blood flow it needs, it makes it very friable or fragile. And so it greatly increases your risk of a leak after surgery, which can be terrible complication. So that's why they take that so seriously. If you're actively pregnant or breastfeeding or lactating, this is not a time to go through weight loss surgery. You have other priorities at this time, and you will need to wait at least a year after having a baby for weight loss surgery. If you have an untreated psychiatric illness, so schizophrenia, bipolar, and you're not stable on your medications, this is not a time to go through a lifestyle change. Now, some patients ask me, well, what if I have one of those conditions and I've been on the same dose and I've been doing very well and I'm seeing a therapist? That's fine. That means that you're in a good position with your medications and that you are treated for that psychiatric illness and you're stable. That's fine. We just can't do somebody if they're unstable on their medications. You need to be in a good mental frame of mind to be able to withstand lifestyle changes. If you are an active alcohol drinker or you have some drug abuse, this is not the time to go through a lifestyle change. And speaking of alcohol, you need to be dedicated to avoid alcohol at least for the first 12 months after surgery. You may be thinking 12 months is a long time, but what is alcohol made of? Sugar, right? So that's not going to support weight loss. And the other thing to know about alcohol with weight loss surgery is after you have your anatomy altered with weight loss surgery, if you take a small amount of alcohol, it's going to impact you big time. Your body will process alcohol much faster after weight loss surgery, which means it's going to impact you very quickly. So you can have a small drink like you maybe did before surgery, and you're really going to feel a big difference, which means that you should not drink right after as well. So if you were to have a drink after weight loss surgery, my recommendation would be to be with somebody that you trust and be somewhere safe. The last thing you want to do is to get behind the wheel and have an accident and it be because you were drinking and you didn't realize the impact on your body. So that's a big safety issue that you need to be very aware of. Current treatment for cancer or chemotherapy would exclude you from having weight loss surgery at this time as well. You would need to be in remission for several years for a bariatric surgeon to consider you for weight loss surgery. Lastly, you need to be very willing to make diet and behavior changes. If somebody were to come to us and want weight loss surgery, but they're not willing to change their food choices, portion sizes, or behavior with food, they're not going to be successful with weight loss surgery. Remember how I told you this was not the easy way out? Obesity is a lifelong chronic condition. So this isn't the easy way out. As a matter of fact, this is just the beginning, because when you have weight loss surgery, some emotional issues may come up for you, or you may discover that you have emotional eating or food addiction problems. That's when you need to see a counselor to get these things under control, but you have to be willing to change to make this physical tool effective for you long term. When we look at the rates of chronic issues that improve or get resolved after weight loss surgery, it's pretty interesting. So type 2 diabetes, we can improve it by 86% of the time, and about 78% of our patients go into remission with diabetes. As far as hypertension or high blood pressure, 78% can be resolved with weight loss. Same thing with hyperlipidemia or high cholesterol, 78%. Now you might be wondering, why is that number higher than that if I'm going to lose the weight? Well, that's because there's a genetic component with high blood pressure and high cholesterol. That means that your family members may have had it and you've inherited that. Well, we can't change your genes, but we can help you with your weight. So that's why that number isn't 100%. So if you fall into that category where it's hereditary, you may still have issues, but we can get it under much better control after getting your weight down. Obstructive sleep apnea. Almost 86% of the time we can throw those CPAP machines or BiPAP machines to the curb. But you have to be very careful with that. About a year after weight loss surgery, we do recommend having another sleep study to make sure that you're safe. After all, when you're sleeping and you have sleep apnea, you're not aware of what your body's doing. So you have to be safe and make sure that you are in a much better position to be able to do without that machine. Now, when we talk about the preoperative evaluation or the steps that our patients have to go through before weight loss surgery, it can be very overwhelming for our patients. But I want to assure you that's what our team is here to do. We're here to help you walk through this journey of weight loss and get you where you need to be. So whether it's here in our hospital program or at your surgeon's office, all members of our team are here to help you with that. We have financial advisors in both of our offices, dietitians, bariatric surgeons, bariatric nurses, and we're all here to help you. You're not in this by yourself. So yes, you will have a very thorough history and physical taken in the doctor's office. They're going to want to know in detail your medical and your surgical history. They're going to want to know your medication list. They want to know what type of medications, dosage, and how often you take them. But they're also going to want to know what foods trigger you. What are your eating patterns? What do you struggle with? Are you somebody that struggles with a food addiction or an emotional eating disorder? We need to know those things ahead of time so that we can set you up for success after surgery. Your surgeon will also help you choose the right surgical procedure for you. It is your choice which procedure you go with, but your surgeon is going to give you their expert opinion in which surgery that you may do better with, depending on your history. All of our patients go through a psychological evaluation. This is not to decide whether or not you're a candidate for surgery, but it's more to give you advice on what issues you have and what you need to work on to be the best you that you can be and to maximize your weight loss after surgery. Your bariatric surgeon may send you to other doctors for clearances before he's willing to do surgery on you. For example, if you have heart issues or you have type 2 diabetes and your hemoglobin A1C is out of control, you see a lung doctor, your surgeon may ask for you to go to those doctors so that we can optimize your health before surgery so that you can have a safe procedure. We definitely want you to have a primary care. If you don't have one now, we'll want you to get established with one, and we're going to want a letter from them that says they support your weight loss surgery decision and are willing to care for you after surgery. You need a complete support team after surgery, and that includes not only your friends and family, but your medical team as well. Submission for insurance. If you're somebody who does have insurance coverage for weight loss surgery, our goal with our financial advisors is to submit you and get you approved the first time. So I want you to just rest assured that's our goal, is to get you approved. If for some reason we don't get you approved the first time, we may have to go back to the insurance company to find out, are we missing some information that they need? Do we need a little bit more detail? Or does the surgeon need to get involved in your behalf and do a peer-to-peer panel session with the insurance company physician to get you approved? But our goal is your goal, which is to get you to surgery. The hospital course, how long does surgery take? It takes about 1 to 2 hours depending on the surgery that you choose. Most of our patients stay in the recovery room for about 1 to 2 hours so that you're awake and alert and breathing well with your oxygen at a good level. And the things that you would need to do to leave the hospital after surgery is you need to make sure that you're drinking well. We do recommend 1 ounce of fluid every 15 minutes. Remember, you're going to have a small pouch of a stomach. You're not going to be able to take much in. So hydration will be key, and that's the #1 thing that brings patients back to the hospital is dehydration. So we've got to make sure that you've got to drink before you leave. In addition to that, you're going to need your pain and nausea under control, and you're going to need to urinate or void on your own as well. And all of our patients need to come to the hospital prepared to walk. You're going to have to walk every 1 to 2 hours after surgery to prevent complications like blood clots that could develop in your lungs. When you're able to meet all of those goals, then you're ready to go home. About 90% of our patients go home the next day after surgery, so they only have to stay 1 night in the hospital. If you're not meeting these goals, we may extend your stay and you may have to stay a second night. All of our surgeries are done laparoscopically, and some of them are using the Da Vinci robot. Laparoscopic means that our surgeons are able to do the surgery through small puncture holes in your abdomen. You'll have about 5 to 6 of those, the size of my pinky nail. And all of those surgeries are done just like having your gallbladder removed. So it's a simple technique as far as getting in, but the surgeries are complex underneath. But the benefit of it being done laparoscopically is that you have a shorter hospital stay, your healing time is greatly diminished, and you have fewer wound complications or infections related to that. So what's your activity after surgery? Well, most of our surgeons will tell you that you can't lift greater than 10 pounds for 2 weeks. So if you have a small child or you've got a very active job, you need to prepare for that ahead of time so that you can heal and you can get used to eating and drinking in a new way after surgery before you go back to work. So most surgeons will tell you at 4 to 6 weeks after surgery, you can go ahead and go back to your normal routine. But at that time, you also need to be thinking about what's your activity going to be. Are you going to increase how far you walk? Are you going to begin to lift small weights at home or exercise bands while you're sitting down? Or are you going to join a gym? You need to have a plan for your activity. So if you're taking off work and you're making plans, you need to plan to be out of work anywhere from 2 weeks if you have a sedentary desk job or 4 to 6 weeks if you have a heavy lifting job. Possible complications after surgery. Any patient that undergoes anesthesia greater than 30 minutes, regardless of the procedure, is at an increased risk of developing blood clots in their legs or lungs and developing pneumonia. So the biggest thing for you is going to be walking after surgery. That's the number one thing that's going to help to prevent a lot of these complications that we're talking about. We've already discussed the leak that can happen after surgery and what we do to prevent that, but that is a leak to a risk of developing a gastrointestinal leak. Pneumonia we've discussed. You're going to need to take deep breaths after surgery to prevent that. Wound infections, it is possible, but it's greatly reduced because we have the small incisions. Some patients with the gastric bypass may develop something called a stricture 4 to 6 weeks after surgery. Remember how I told you that the pouch is small and that the intestines are brought up and hand sewn to the bottom for that outlet? In this area, about 5% of our patients develop a stricture, which means that that area that was hand sewn can heal down and be very small over that period of time of healing, which means that patients may call us saying, I was able to eat solid food, now I don't feel good when I eat solid food and it comes back up. That would be a stricture. The good news is it's very easy to treat. The surgeon will go down with an endoscope and do what's called a balloon dilatation. So they put a balloon in that area and they expand that balloon out so that they can widen that outlet so that it's comfortable for you to eat and drink, but it's still closed enough for you to feel restriction so that you can feel fuller faster. Again, ulcers are a risk. Bleeding is also a risk with any surgery, but specifically because we're cutting and we're sealing, and so we do have to watch for bleeding. We've talked already about the nutritional deficiencies of vitamin deficiencies and how it's very important to take bariatric vitamins after surgery. Now here's the big thing, right? When you leave this video, you may go home and you may have friends or family members tell you, isn't that risky? Why would you do that? Isn't weight loss surgery dangerous? Isn't it worse than the weight that you're carrying around? And the answer to that is no. When we look at the morbidity or the death rate associated with weight loss surgery, the statistic is 0.13%, less than 1%, but very, very low. When we look at gallbladder surgery, the death rate associated with that is 0.7, and many people have their gallbladder out. Some of you may have already had your gallbladder out. If somebody were to have a hip replacement surgery, the death rate is 0.93. So when I tell you that, it kind of puts things into perspective as far as how dangerous the surgery itself is. But some other things I'd like to leave you with is the benefits of weight loss surgery. We know that weight loss surgery can result in significant weight loss, but it also helps to prevent, improve, or resolve more than 40 different obesity-related diseases. There was also a study done that shows that that obesity in general reduces a person's risk of, surgery in general reduces a person's risk of premature death by 40%. And so that's really important for you to know so that when you're choosing weight loss surgery, you know the facts. Follow-up care. It's really important for you to develop a long-term relationship with your bariatric surgeon and their team in the office setting, as well as the dietitian. That's what's going to make you successful. Statistically, patients who follow up with their surgeon and attend some form of a support group have a higher incidence of maintaining their weight loss long term. What I'd like our patients to know is that if you have surgery here at Northeast Georgia Medical Center, you have a lot of resources that are here to help set you up for success. Things like a bariatric dietitian here in our hospital program that you can see for free as many times as you need. So if you've already seen the dietitian in the office setting, but you need a little bit more or you're struggling, that's a time to reach out and get engaged with our bariatric dietitian. We also have therapists available. So if you have surgery and you start to grieve food or have emotional issues regarding your food, you need to see a therapist to get that under control to make yourself successful. Some other things that we have that are free to all of our surgical patients is free cooking classes every month, free exercise classes every month, and also a clothing closet where our patients can go and shop out of gently used clothes. So as you lose weight, you have an option for clothing. Vitamin and mineral supplementation is key to prevent vitamin deficiencies after surgery. Some other key rules to be successful is that you will need to find a way to get protein in your daily diet in about 80 to 100 grams, which is difficult to do with food alone, so you may need to take some protein supplements. You will need to drink 64 to 80 ounces of liquid a day to keep yourself hydrated, which means that in between meals you'll need to drink. And then also you'll need to find some form of exercise, and for some patients it's literally nothing more than exercise bands to begin with, but then over time as you lose the weight you will need to progress so that you can get up to 5 days a week, 30 minutes at a time. So it's really important for you to reach out if you have issues and you need support. So next you're going to hear from Giselle Cram. She is our bariatric dietitian here in our hospital program, and she's going to talk to you about what's it like when you eat after surgery. Afterwards, you're going to watch some short videos of our surgeons, and then I'd like you to reach out to me and let me know where this sits with you, if you have any questions, and how you'd like to move forward.
Hi everyone, my name is Giselle Cram. I'm one of the bariatric registered dietitians here at Northeast Georgia Medical Center. So today we're going to talk about the nutrition aspect of weight loss surgery, give you a bit of a review of what to expect after you get weight loss surgery. So the most important thing is that we're going to talk about is quality over quantity. So with weight loss surgery, we're changing the anatomy of your GI. You might not absorb all the nutrients that are necessary or the vitamins and minerals. So we want to make sure that when you do choose food, you're choosing quality food. And the dietitians in the program will guide you through this and teach you what that means. But just to give you an idea, one of the things that we're really going to talk about is proteins that are leaner. Leaner meaning lower in fat. Avoiding fried foods or trimming any visible fat is a way to cut back on the fat content. Also, we're going to talk about easier to digest proteins like fish, seafood, poultry. After weight loss surgery, we will gradually get you used to tougher textures and consistencies. So these easier to digest proteins are going to be really helpful, especially during that time post-surgery. Another really important thing is to reduce intake of simple carbohydrates, such as added sugars and white flour, and also reducing refined starches, such as white rice, bread, and pasta. We're going to recommend that you consume more of the complex carbohydrates, like whole grains, whole wheat, instead of the refined. These contain more fiber, more vitamins and minerals, and again, touching back on that quality aspect of it, these are going to be much more nutritious for you. Another thing that we're going to talk about is increasing non-starchy vegetables. Non-starchy vegetables is a fancy term for those vegetables that are very, very low in carbohydrates, and they are packed with water, fiber, vitamins and minerals. If you see that image down below, you see all those colors. Different colors also represent nutrients. We're going to recommend a lot of things like peppers, broccoli, onions, eggplants, a bunch of different vegetables. We'll teach you how to prepare them if you're not very familiar with these. Our dietitians are really good at explaining how to incorporate these in recipes, give you tips on how to make them tasty, because oftentimes patients, the reason why they may not consume these vegetables is because they dislike the taste. So we will provide some recipe ideas, seasonings that you can add to these vegetables to make them very palatable, and also cooking techniques that can enhance the flavors of this food group, which is so important. Another very important aspect to consider after weight loss surgery is fluids, hydration. With weight loss surgery, the size of the stomach pouch is greatly reduced. For that reason, it's difficult to get all the water that you need in one sitting or 2 or 3 sittings. It's difficult to gulp. You're not going to be able to gulp a lot of water in one sitting. So sipping your water, small sips throughout the day, is going to be the best way to meet your hydration needs, which is around 64 ounces a day. It could be less or more depending on your needs, but that's a good average. Very important is going to be to implement the 30-30 rule, which means that you would have to stop your intake of fluids 30 minutes before the meal and wait to drink anything at least 30 minutes after the meal. If we think about that sleeve gastrectomy, which is the surgery where the stomach pouch is in the shape of a banana, with that surgery, you still have the pyloric sphincter, which is that little valve that opens and closes. If we eat and drink at the same time, that small stomach pouch is going to get full very quickly, and the contents in the stomach may actually come out, which is not a good experience for patients. Feels very uncomfortable. So this recommendation is more for safety. The 30 minutes after the meal is to allow yourself to really be able to digest that food properly. For patients that have the Roux-en-Y gastric bypass surgery, if you consume food and drink fluids at the same time, that can cause the food to go down into your intestine much quicker, and that can actually cause some discomfort, or it may not allow you to feel satisfied when you should feel satisfied, because the food is just going down really quickly. So these are the reasons why we would implement the 30-30 rule. We're going to recommend to replace sugary beverages with water, low-fat milk, unsweetened almond milk. We'll also give you other alternatives if you don't, if you have lactose intolerance or food allergy or anything like that. So working closely with the dietitian is going to be key for that. But we're going to recommend to avoid, consuming calories through your beverages to help you with your long-term weight loss. Reducing carbonation and caffeine. The caffeine can be an irritant to the stomach lining, and there's a risk for formation of ulcers in the stomach pouch. So when we recommend no caffeine, it is really for safety. So that's the reason. And the carbonation can make you feel very uncomfortable with all those air bubbles. And also, we recommend to avoid alcohol for at least 12 to 18 months after surgery. Now, here you can see what a healthy plate looks like before surgery. If you looked at the right hand, you'll see that half of the plate is covered with those non-starchy, those low-carb, low-calorie vegetables. To your left, top left, a quarter of the plate is recommended to be covered with your protein-rich foods. And then underneath that is the starchy vegetables, or the whole grains, would be a quarter of the plate, also including a small serving of fruit and a small serving of dairy with your meal. So the food groups that we recommend are not going to change. What's going to change is the proportion, the serving sizes of those food groups. So here you can see the plate after surgery. First of all, we're going to recommend that you choose smaller plates and consuming smaller portions, and sometimes using smaller silverware is very helpful for patients. And we're going to shift the focus on protein. Protein is very important for wound healing, immune health, muscle strength. So we are going to make sure that we teach you all the different sources of protein, and we're going to ask that to put an extra focus on that. If you see on the right side of the plate, half of the plate here is covered with protein. Compared to the one before that, you can see that half of the plate was covered with those non-starchy vegetables. So after surgery, half of the plate would be with protein, a quarter of the plate with the grains, starches, or fruits, and a quarter of the plate with those low-calorie, low-carb, non-starchy vegetables. Shortly after surgery, you won't be able to consume a solid diet. We will teach you how to transition from a liquid diet all the way to a soft diet, and then you will eventually be able to move on to a regular solid diet. During the liquid diet, the protein supplements are going to be your main source of protein. And there will be some requirements for these protein supplements. The first ingredient should state whey protein isolate. So that whey protein has all the amino acids, all the building blocks that we need. It should be around 20 to 30 grams of protein per serving, okay, and less than 7 grams of total carbohydrates. And the carbohydrates is mainly to prevent that dumping syndrome that Amy described previously. All right, so another really important thing is we're going to put a lot of focus on nutrition education, teaching you how to eat healthy, how to build a meal that will both provide you the nourishment that you need, but also help you with your weight loss goals. But another really important aspect is changing behaviors, changing your habits, and we will also touch base on that plenty. For example, eating slower, eating at a slow pace can, even though it's a very small change, it can absolutely have an impact on how many calories, how much food you consume at the end of the day. So that's something that we're going to talk about. Chewing your food properly, having positive thoughts, being mindful when you consume food. So this is a concept where we may be going by our day and not really paying a lot of attention to our food choices. So the dietitians will work with you and help you how to be more mindful of your choices. And it's going to help you make better choices and help you with your weight loss goals. Like I mentioned earlier, focusing on quality over quantity. Also eating at the table, which reduces distraction, is something that could really help. Eating around 3 to 5 meals a day, not skipping meals. So it's something that's going to be very important is to stick to the meal times. When you stick to the meal times and avoid any kind of snacking in between, that really helps with the weight loss goals. Planning ahead of time. Here at the hospital, we provide support groups, and recently that was one of the topics that we talked about, how to plan appropriately for your week so that you have healthy foods available. The no gum and straws, the reason we recommend that is because when you chew gum or you drink beverages from straws, you may swallow some air, which can cause discomfort in the stomach pouch. Another very important thing, which I mentioned briefly before, is the mindful eating. There are some strategies that will teach you to be more mindful. One of those that has proven to be very helpful for patients is food journaling. There is evidence behind the fact that the patients that journal their intake of food and beverage have improved weight management. They lose more weight, maintain weight loss longer, and catch any regain faster. It also helps patients with accountability, and it helps the dietitian identify if there are any food groups that are missing or any nutrients. So bringing that food journal to your dietitian helps. We can take a look at that and see if there's anything that we notice that might be missing. And preventing vitamin and mineral deficiencies is absolutely important. The anatomy of the GI tract has changed, and you will not be able to absorb or metabolize some nutrients as well as before. Therefore, it is super duper important to stick to the vitamin and mineral regimen for the rest of your life. So that will include a multivitamin, calcium citrate, and it may include B12, iron, biotin, a B complex, vitamin D. So working closely with the surgeon and the dietitian is important to make sure that you are taking all the vitamins and minerals necessary to prevent any deficiencies. And that's all. Thank you so much. Remember, just take one step at a time, focus on you and building a healthier lifestyle. And even now, it's a great time to start on some of those changes.
My name is Alex Wynn. I'm a bariatric general surgeon. Been practicing in the Northeast Georgia area since 2008. I like several things about bariatric surgery beyond just the surgery part. I get it that when patients walk through the door, they're taking a huge leap of faith, trusting you with their life and their well-being. My best advice to any patient is always do your research. Understand the different surgeries, understand who you're considering to do your surgery, and understand where you're having your surgery done. But the one thing I always tell patients is don't do it for anyone else. You have to do it for yourself. You know, whether you're motivated by having to care for a young child, or whether you're motivated by not wanting to have your second heart attack before you turn 40, whatever it may be, you have to do it for yourself. I get asked a lot on what my underlying philosophy in taking care of patients would be. Back in my early days of training in surgery, I had a really wise surgical attending who taught me the mama rule. What's never failed me is that I live by the philosophy of treating each patient as if they were my mother. I always ask myself, and it has always steered me in the right direction, that if that was my mother, the patient was my mother, how would I want the physicians to take care of my mother, you know? And using that as an underlying tone of approaching all patients, whether they're bariatrics or general surgery, it's never failed me.
I grew up wanting to be a primary care doctor like my dad, and realized when I got to medical school that I really liked operating. So I get to have the best of both worlds in a lot of ways. I get to do general surgery, very refined, very specific type of general surgery, but I also get that long-term care and follow-up with the patients that I was looking for when I was growing up. But we get to experience as bariatric surgeons, patients seeing diabetes go into remission, or blood pressure being controlled without medicines. We get to see people walk Disney World for the first time, from the front entrance to the back with their grandkids or kids. That's really cool. And you don't get to have that experience with a lot of other types of medicine, so I love it. Northeast Georgia Medical Center is a great place to have surgery. One, we do meet the national guidelines for Center of Excellence. We've consistently done that for a very long time. The nurses are incredible. The anesthesia staff, the people that make this possible, do a great job. It's not just the surgeon being safe, but all the parts of the puzzle falling into place and falling in well. What I would tell a patient who is considering bariatric surgery is to learn. Learn as much as you can. Talk to friends, talk to family. Go on the internet and talk to some virtual people. But at some point, sit down with a surgeon you feel comfortable having a relationship with, and really do a deep dive on your own personal history. Do a deep dive on what your goals and aspirations are. The surgery itself is not a finish line, it's a starting line. It's a starting line for the treatment of a chronic disease, which implies chronic ongoing care. So if you feel comfortable with that physician, with that surgeon, that you could see them for the rest of your life, that's the first step, I think, to having a successful surgical event.
Well, bariatric surgery can be a great option for someone who is morbidly obese. because we're going to have good outcomes and we're going to be successful. And a lot of these patients have tried other things to lose weight, and they're skeptical because they've tried it, they might have lost the weight and they've regained it, and they want to know why this is different. Well, this is different because we're going to provide them with a tool that will allow them to continue with this weight loss journey long term. And we're going to teach them how to use the tool, and we're going to follow them. Our discipline of bariatric surgery is a discipline that we can prevent so many diseases by treating this one condition, obesity. And in treating that one condition, we can prevent that renal failure from the diabetes because we can send diabetes into remission. So this is a very powerful discipline. We build long-term relationships with our patients. You know, the follow-up is key to long-term success with bariatric surgery. I finished my training in 1998, and I spent 4 years in the Army doing trauma, as well as doing bariatric surgery. I did start a program at Fort Campbell before joining practice here in Gainesville. So I've been here since 2002, and I currently practice 99% of what I do is bariatric surgery. I do very little of anything else. So this is what I do. I guess the best part about being a bariatric surgeon is just knowing that you have a powerful tool, knowing that when that patient shows up in your office on oxygen with a walker or a wheelchair, knowing where that person's going to be 6 months later, knowing that you can get that person off that oxygen, get that person out of that wheelchair. That's the fun part of my job.